Thank you so much. Like you said, I'm the director of the Consultation Liaison Psychiatry Service at Morningside and West. I'm also the Associate Program Director of the General Psychiatry Residency. We'll be talking to you guys about insomnia today, where we're going to go over the identification and evaluation of insomnia, really trying to understand how to put our patients' complaints into a real diagnostic framework, and then also talk a little bit about management. So 33% of the US adult population experiences insomnia on a nightly basis. And when you think about it, that is pretty remarkable. What that means is, of a third of you here, roughly, are going to experience restless, poor sleep on a nightly basis. And that's really an enormous amount of individuals if you think about it. There are, about 330 people in the United States. That's like 165 million people are experiencing insomnia. And when you look closer at the slide, you see that even more than half of the population has had insomnia at one point or another, not just every night. So this is a really common issue that we see. And in fact, it's the second most common complaint. The first most common complaint is upper airway congestion, sniffles, that kind of thing. And the third one after insomnia is pain. So it's something you hear about constantly. So we're going to start off with a case just to describe some of the points I'd like to make about diagnosing insomnia. So this is a 71-year-old man. He's complaining of unrefreshing sleep following his retirement. The onset of the problems was about 4 months ago. The frequency of the insomnia is about 4 to 5 nights per week. So it's a fairly common problem for him. He says that his mind spins when he goes to bed, which is a really commonly described experience with insomnia. He feels washed out the next day. He has low energy, he gets irritable. There's no medical contributors to his physical exam or to his presentation. His physical exam's normal. His mental status exam shows some psychomotor slowing, although he says, my mood's fine right now. His affect is a little restricted, and there are no other medical comorbidities or mental status issues, and his cognitive functioning's intact. So in terms of the diagnosis for the 71-year-old man, what additional criteria do we need to have this person meet diagnostic criteria for a DSM-5 insomnia disorder? Number one, the duration of the insomnia must be more than 6 months. Remember, for him, it was less than that. It was about 4 months. Number two, the difficulty with insomnia has to occur nightly. For this guy, he had trouble sleeping 4 or 5 nights per week. Number three, we have to have laboratory confirmation of some sort of sleep latency, which is really just the time it takes to fall asleep of more than 1 hour. Number four, he must not meet criteria for a major depressive disorder. And number five, it doesn't matter because he already meets criteria for insomnia disorder. So any thoughts from you guys about what the answer is here? Just in terms of thinking about his diagnostic picture. So the correct answer is based on what we know, he already meets criteria for insomnia disorder. And on the next slide, we're going to get into a little bit about why that is. So first off, for insomnia disorder, you have to have the complaint, right? You have to have dissatisfaction with sleep, quantity or quality. And patients will say, I don't sleep long enough, I wake up a lot at night, I wake up feeling totally washed out. And those are all pretty common initial complaints of insomnia. For criterion B, you have to have trouble with stress or some sort of impairment from it. Remember, our gentleman here felt washed out throughout the day. He was tired, he was irritable. There was a sense of his not functioning correctly. He had some daytime impairment. For criteria C, it has to occur more than 3 nights per week. So the frequency has to be more than 3 nights, and this guy met that criteria. He was having unrefreshing sleep for 4 to 5 nights. Criteria D, it has to be more than 3 months in duration, not 6 months as the question stem asked. And then for item E, the person has to have an adequate opportunity to sleep. So some people are sleep deprived. Like they get home late from work or from whatever else they're doing. They get into bed at 2 in the morning, and then they have to wake up at 6 or 7 in the morning to get up to go back to work or for childcare, and they feel tired the next day. That's not insomnia. That is sleep deprivation. They can fall asleep, but they just don't have an adequate opportunity to get the amount of sleep that they need. But what I find interesting about this criteria is it doesn't say you have to exclude like major depressive disorder or other psychiatric or medical comorbidities. The criteria says that you can specify if the insomnia occurs with those other disorders, right? So, what this tells us is that insomnia in this particular diagnostic rubric is being taken as a disorder in of its own right. Insomnia is an independent disorder that can comorbidly exist with other medical issues or other psychiatric issues. And so you can have depression and insomnia occurring at the same time. You can have GERD or headache that's interfering with sleep and creating a pattern of sleep that's consistent with insomnia at the same time. One of the challenges we have with insomnia is we're never totally sure where the causality lies. So, with a psychiatric illness, is it that the insomnia occurs as a result of a major depressive disorder? Dysregulated sleep is a common symptom of major depression, or is it that the insomnia potentially caused the depressive disorder, or is there no relationship between the two? And this diagnostic rubric allows us to just go ahead with the diagnosis without really clarifying that chicken and egg, what caused what issue. It allows us to kind of sit in that ambiguity and say this person meets a pattern consistent with insomnia, and then maybe has other comorbid issues that could be contributory. So that way, when you're talking to a patient who's distressed about their sleep, you don't have to say to them, well, you don't have insomnia because you're depressed, or you don't have insomnia because you have GERD. You can acknowledge your pattern of sleep is consistent with insomnia, and it also sounds like that you're depressed, or it also sounds like you have GERD. And let's look at this and figure out the best way to get you sleeping again and feeling better. So thinking about chicken or egg, we might ask ourselves, what causes insomnia? And there are many theoretical formulations about the etiology. We still don't quite know, but one thing we do know is there's a significant hyperarousal along multiple axes that are psychological, physiological, biological in nature. We see hyperarousal manifestations along the lines of body metabolic rate, which is much higher in insomnia, cognitive arousal. You picture someone with insomnia, kind of like the person in the top right-hand corner, sort of lying in bed, feeling their minds are spinning around rapidly. EEG hyperarousal, we can actually quantify this hyperarousal in the brain on EEG during multiple stages of sleep. Heightened brain metabolism, so brain metabolic rates are elevated in insomnia. They're actually really on hyperdrive, not only at night, but also during the day as well. You see sympathetic activation is high, the hypothalamic pituitary axis along multiple planes is heightened. So insomnia in many ways is a disorder of hyperarousal and hyperactivation, and not just during sleep, but also during wakefulness. So you can actually say that insomnia is in fact not just a disorder of sleep, it's a 24-hour disorder that affects us throughout the entire day. And we see this play out in terms of like how people are impaired by insomnia. So what are kind of some of the major impairments that it causes? We know people with insomnia have higher rates of various morbidities, both psychiatric and physical. They enjoy life and relationships less so. They have a decreased quality of life. Their absenteeism rate is higher on the job. Their performance on the job is also lower. We know that they have significantly higher rate of motor vehicle accidents, a high risk of falls and accidents, Their healthcare costs increase as people develop insomnia, diminished concentration and memory. You can also see a lower pain threshold. That is, people with insomnia feel pain more acutely. Interestingly, when you help individuals sleep better, their pain thresholds go up. That is, they feel pain less acutely when their sleep improves. Hypertension and diabetes can begin to develop with chronic insomnia. So individuals who do not yet have diabetes or hypertension, who then have insomnia for multiple years, tend to begin to develop diabetes and hypertension at rates higher than similar folks who do not have insomnia. And finally, people with insomnia die with greater frequency. There's a higher mortality rate associated with individuals with insomnia. So to revisit that chicken or egg question, is insomnia the cause of these impairments? Is it only comorbid with these impairments? Is there some predictive nature of these impairments with insomnia? We don't really know. The research in this area needs to be better studied, but we do know that there is something about insomnia that increases the vulnerability to all these impairments. And at least with regard to depression, which is what I spend a good amount of my time thinking about, as well as bipolar disorder, there is emerging research that insomnia during periods of psychiatric disease remission is associated with poor prognosis and a higher likelihood of recurrence. And there's some clues that the Erection System, which we're going to talk about in a little bit, might have something to do with this a little bit. So I work in a integrated primary care clinic, and I'm often referred patients from my colleagues to manage insomnia with the expectation that their sleep disturbance is due to an underlying psychiatric issue. And about 40% of the time that is absolutely the case. Insomnia is comorbid with multiple psychiatric disorders: alcohol abuse, drug abuse, dysthymia, major depression, anxiety. But 60% of the time, there's no psychiatric issue at all. And the comorbid issue is either medical in nature or environmental in nature. So this is a 2011 prospective cross-sectional study that will help us clarify some of those comorbid medical disorders are. So looked at over 3,000 adults who underwent polysomnography, and it found that insomnia was 2 times higher or 2 times more likely to occur in adults with pre-existing medical disorders compared to those without pre-existing medical issues. And the primary disorders they found an association with were heart disease, hypertension, diabetes, gastric ulcers, arthritis, migraine, asthma, COPD, neurological issues like stroke and epilepsy, as well as gynecological issues like menopause, urinary urgency, and fibroids. And not only was the prevalence of insomnia higher if a study participant had one of these medical disorders, but that prevalence increased further as the number of comorbid medical disorders went up. So a patient who's presenting with a chief complaint of insomnia in your primary care clinic, it might raise your antenna to think about whether one of these comorbidities is present. So when evaluating a patient with insomnia, keep in mind some of the medical conditions that can easily disrupt sleep. Cardiac conditions that affect heart rate or breathing while lying down, breathing issues that affect your body's ability to oxygenate and take breaths deeply. GERD is worsened when we lie down. Hepatic encephalopathy can cause a hypoactive somnolent delirium that can lead to dysregulation of the sleep-wake cycle. Anything that causes musculoskeletal pain will prevent sleep onset and can also wake us up from sleep. Many neurological conditions disrupt our brain's ability to balance sleep and wakefulness. Endocrinological issues like hyperthyroid or menopause, any dermatologic issues that cause us to feel itchy or uncomfortable or cause pain, that's going to disrupt our sleep. And of course, neurological issues like BPH or an overactive bladder that gets people out of bed constantly throughout the night, going to the bathroom, is also going to cause some sort of disruption of sleep. So when your patient comes in and says, doctor, I have terrible insomnia, I need treatment, and you want to start thinking about whether they fit into that framework, well, one step that you're going to take is thinking about other common sleep disorders that can also disrupt sleep onset and maintenance and may feel like insomnia to your patient. So probably the most common of this is restless leg, which is this irresistible urge to move the extremities, and it's only relieved by moving. Then there's periodic limb movement disorder, which involves repetitive involuntary movement of the legs and arms while trying to fall asleep or while already asleep. And these people are like the kickers. Their partners frequently are the ones that get them in to see the doctor because they're like, you're kicking me throughout the night. I can't stand this. Rapid eye movement, sleep behavior. So these are the sleep talkers, the sleep walkers, the vivid dreamers. Delayed sleep phase disorder. So that's going to be someone whose sleep-wake cycle is predictably skewed. It's not that they can't fall asleep, it's that their bedtime and wake time is a few hours off from everyone else's, and that ends up causing them problems. There's advanced sleep phase disorders. This is the opposite. So people whose sleep is skewed in the other direction. They can't stay awake until their bedtime, and then they wake up too early in the morning. Shift wake disorders is one that probably everyone in this Zoom lecture has experienced to some degree. And that's when we're at work when our brains really want us to be sleeping. And then there's poor sleep hygiene practices that impact sleep, and we're going to talk about those in a minute. This is a logarithm to think about how to initially start management of insomnia. I think if someone comes in and they have a pattern of sleep that's consistent with insomnia, and they also have a comorbidity that is likely contributing, you want to treat both at the first time, treat both at the same time. And if the person comes in and you're not entirely sure what their comorbidity is, or it seems like there is no other medical or psychiatric comorbidity, just go ahead and treat the insomnia first until you properly assess it if there's some other factor that's impacting their sleep. So this is a good rubric that you can use. So when taking a history about insomnia, these are some of the questions that I like to hit during our initial conversation. So is the problem brand new? Is it intermittent? Does it come and go? Is it chronic? Has it been around for a long time? Is your primary issue falling asleep, staying asleep, getting back to sleep after you wake up in the middle of the night, waking up too early in the morning? If the issue is falling asleep, I might screen quickly for restless leg symptoms or a delayed sleep phase sleep disorder. If the person's waking up earlier than they would like to in the morning, I might screen for depression, or I might screen for advanced sleep phase disorder. I want to know about recent travel into other time zones, changing in work shifts that causes the person to go from having to work very late at night to then getting to work really early in the morning. That can sometimes throw off their sleep-wake cycle, especially if their morning wake time is constantly shifting. New physical symptoms that occur during sleep. So snoring and choking during sleep, that can often signify some sort of sleep apnea. Does a person have hot flashes that might be associated with menopause? Are they in pain, or their legs restless? Did they start a new medication that is maybe a little bit more activating, or do they change the time at which they take an activating medication or the dose of that medication? Does the person have a headache when they wake up? Do they have a dry mouth when they wake up? That might be a clue that the person has sleep apnea. Do they have a newly diagnosed medical illness or psychiatric issue that could be contributory? You want to talk about use of substances, both alcohol and illicit drugs, but also caffeine, nicotine, other stimulants that can make it hard for the person to achieve sleep. Changes in the bedroom environment. Did a new construction site go up next door that's making a lot of noise? Does the person have a new sleep partner that snores throughout the night? You want to learn about the person's sleep routine when they're actually getting into bed, what they're doing right before bed, when they're falling asleep. And you have to ask about whether they have daytime impairment, because there are people who are just short sleepers who only sleep for 4 hours or so at night, but don't have any impairment, no fatigue or drowsiness or irritability during the day. And we generally see that pattern of sleep among families. Does the person nap during the day? And also, if you have available, you might want to ask the person's sleep partner what they think, because sometimes the story a person tells is very different than what their partner observes. So someone maybe who has sleep apnea feels like they're awake throughout the night, but really they're falling asleep and waking up from snoring or choking sensation. And they see the hours go by in the clock and they assume they haven't slept at all. And the partners are saying like, no, you're actually sleeping for several hours. There's no real focus specific physical exam for insomnia. You really want to focus it based on what you think the comorbidity might be. Same thing with labs. You might get, if you suspect restless leg syndrome, you might get ferritin or thyroid hormone if you suspect hyperthyroid, or if you think substances are having something to do with the sleep pattern and maybe the patient isn't a great historian or not so reliable, you might get toxicology. And then sleep studies are really only indicated if you suspect an underlying sleep disorder. And sleep studies tend to be most useful for identifying sleep apnea and then some of the REM sleep disorders. After identifying a comorbid issue, you want to address it. So CPAP, BiPAP, oral appliances, surgery for sleep apnea. You can do iron supplementation for restless leg syndrome or treat with an alpha-2 delta ligand. So it's something like gabapentin or Lyrica, or dopaminergic agents like pramipexole or ropinirole. If the person's depressed, you want to treat their depression, address GERD symptoms, any pain or discomfort that's causing trouble falling asleep. And then you also want to look at medications that they're already on and make adjustments if those are contributing to their poor sleep. In terms of treatments for insomnia specifically, there's many different strategies, and cognitive behavioral therapy is probably one of the most useful and beneficial, but it's not always easy to engage patients in, or also to find someone who practices it. Many of our patients use nutraceuticals, herbal supplements, or over-the-counter medications like non-prescription pharmacological agents, and then pharmacologic agents, which we'll talk about as well. So just in terms of CBT, this is a really important treatment for insomnia. There are multiple different types of CBT categories or categories of CBT for sleep. And when you combine the different categories of CBT for sleep in a structured way, that's what's referred to as CBT for insomnia, as you can see down on the bottom of the slide in the bottom row. The strategies in red are the ones that have the greatest amount of data backing them up. So stimulus control usually involves telling patients if they can't fall asleep for, they get into bed and they can't fall asleep after an hour or so, to get up out of bed and do something completely different, not connected to the bed, that's pretty boring, and only to come back to bed when they feel sleepy. And the rationale here is to try and cut that association between the experience of being in bed and not sleeping, to extinguish that psychological association that builds up when a person is spending all of their time at the end of the day in bed in a sleepless fashion, doing everything but sleeping. They're talking on the phone, doing their taxes, eating dinner, watching TV, like everything's happening in the bed. You want to try and extinguish those associations and really just make the bed a place where you sleep and have sex, and that's it. Biofeedback relaxation training. this is really effective and it is really good for patients who kind of have overactive thoughts before they go to bed. It can help quiet those down. And it's pretty easy for patients to learn how to do. And there's some structure modules that they can find online to learn how to do it. Paradoxical Intention. Some people find this helpful. I haven't really, but it's telling patients that they shouldn't sleep at all. So you say to the patient, like, I want you to go home and try not to sleep at all for the next week. And interestingly, people who are maybe a little bit more easily suggestible might respond to this technique well. So going on, some of the data behind CBT. CBT has been shown to work in numerous different studies. This is a meta-analysis of 20 research control studies of more than like 1,000 participants. And you can see that the post-treatment period, which is sleep onset latency, so it's like the time that it takes people to fall asleep, it improved by 20 minutes in the post-treatment time. And then wakes after sleep onset, so that's the amount of time that you're awake once you initially fall asleep, was reduced by 26 minutes. And you might say, like, okay, that's not great. Like, 20 minutes of better sleep isn't life-changing. But believe it or not, that this is the best that any pharmaceutical compound can do. And in fact, it's better than most prescription agents can do. So these are actually really nice numbers. And what's important about CBD is that these changes tend to be lasting. After a year after completing therapy, the data has shown that people are still doing well and have improved sleep. So it's a really fantastic way to produce lasting changes with regard to insomnia. And we're going to talk in a minute about when to recommend CBT for insomnia, as well as some of the challenges that you might encounter with that treatment. So first, we're going to go over sleep hygiene. In terms of sleep hygiene, I think these are many of these skills we know or may already do intuitively, and for some, doing the opposite of them may exist as chronic bad habits. So it's also important to remember that sleep hygiene education is not in and of itself a sufficient treatment for insomnia, but it's absolutely necessary. If patients are violating sleep hygiene rules, the other treatments, they don't work. They're not going to get benefit from that. But by itself, the sleep hygiene has not been shown to work particularly well, but it is necessary in order for other treatments for insomnia to work. So things like getting out of bed at the same time each morning. I think of all the sleep hygiene recommendations, this is probably the most important. It helps reset your circadian pacer in such a way that you have a 24-hour rhythm and not a longer rhythm. And really the best way to do that is to get out of bed at the same time every morning. The time that you go to bed is actually totally irrelevant. It's really when you wake up that's most important. And of course, getting light exposure early in the morning and during the day is important for your circadian rhythm. Worrying and its associated activation at night is common in insomnia. So maybe suggesting that a patient set aside a time that they can worry as much as they want, but that time not being bedtime is sometimes helpful. So you can say, like, maybe spend half an hour before dinner or after dinner, just kind of getting into that mental state where your thoughts are moving freely. You can turn off your phone and TV and stuff. And, if you want to, you can write them down. That's sometimes a useful strategy, or make a list. And that allows the person to let go of those worry thoughts and also uncouple the ritual of doing that daily worry with getting into bed and trying to fall asleep. You also want to keep your environment comfortable. You want your room to be at cool temperature. You want to have a relaxing bedtime routine that maybe you do every night and you do consistently. A warm bath before bed can be helpful. And then other interventions that are helpful are eliminating caffeine and nicotine and other stimulants later in the day. For some people, caffeine elimination after lunch is very helpful. You also want to screen for the amount of caffeine that your patients are consuming. So an 8-ounce cup of coffee is about 90 milligrams of caffeine. That the FDA suggests taking in no more than 400 milligrams is the max dose of caffeine. And above that really is associated with caffeine toxicity throughout the day. And so that means no more than 36 ounces of coffee, which may sound like a lot, but if you think about the large cups that they have in the cafeteria or at Starbucks, those are like 16 ounces. So after 2 of them, you're already at your max limit for the day. And so it's really easy to get into that toxic range and to develop either symptoms of caffeine withdrawal at bedtime or to just be overstimulated from the caffeine. You want to try not to nap during the day. You want to avoid focusing on time cues like the clock while trying to fall asleep. So a lot of people have these light up digital screen clocks. Removing them from the room can be helpful for some people, especially those who like stare at the clock and watch the hours roll by at night and get more and more anxious. One of the things that we try to emphasize is avoiding bright light exposure, especially close to bedtime. So a lot of our electronic devices that we use, like a television, a cell phone, an iPad that we have at arm's reach, and we tend to look at when we're in bed right before going to sleep. Even though the light's not particularly bright on those devices, they tend to have a high degree of blue spectrum light, which is the same frequency as morning light and can actually send a signal to your brain to delay the onset of melatonin at nighttime. And that sometimes can be associated with difficulty achieving sleep. So blocking those lights is useful. There are some people who can't help but look at screens at night. And for those, I might suggest a blue light filter glasses, which are available commercially. And I'll tell people to wear them for 2 or 3 hours before going to bed, regardless of what they're doing. And some people will reset their cell phones to night mode. Doing that by itself really isn't going to be helpful. It's not sufficient, but sometimes wearing these blue light filter glasses can be useful for people who really either need to look at a screen before bed or just are not going to be able to extinguish that behavior of being on their cell phone in bed. So thinking about who's going to benefit from CBT for insomnia versus who we should maybe start on medication, here's a table that can help guide you a little bit. So starting with pharmacotherapy over CBT is optimal if there's factors that suggest that the person's going to continue to make sleep hygiene violations, or it's going to be hard for them to make cognitive and behavioral changes. Really, these are the people who are not good candidates for therapy, who aren't really willing to engage in a disciplined way. Also, if there's a need for rapid improvement, if being able to get back to sleep quickly matters a great deal for this person. So the patient's so tired that they're causing a big interruption. They have something really important to do. They're not able to work, and they need to get back to work, and they can't wait for the time it might take to learn CBT, then pharmacotherapy certainly is going to be faster and more immediate. The same reasoning for time limitations and people who just can't come in regularly on a weekly basis for therapy. You might want to start pharmacotherapy with them. Finances, unfortunately, tends to be a factor that favors pharmacotherapy over CBT. And another systemic issue is really just access to therapy, finding a therapist who's trained in CBT for insomnia, and then once finding them, getting an appointment with that person, because they're probably in high demand because there are not enough practitioners out there who are well trained or adequately trained in this type of treatment. So other people for who CBT is probably better, you want to maybe think of a patient who needs a sustained clinical improvement, or maybe someone who has a history of substance abuse and might misuse some of the pharmacotherapy. For people where adding a hypnotic and increasing polypharmacy is going to complicate their clinical picture. And also individuals who want to get off of chronic use of sleep medication, CBT is a great tool to use. People who learn CBT before discontinuing sleeping pills tend to have a much easier time getting off of them. So these are people who are maybe been on sleeping pills for a chronic period of time, and they're starting to cause more harm than good, but they're having trouble letting go. CBT for insomnia would be a great referral to make. Now, in terms of other substances people with insomnia use, people use all sorts of things to help with their sleep, and usually by the time the patient sees me, they're already have initiated something. Oftentimes it's a dietary supplement. So it's really important for us to know about these and know which ones are safe, which ones are effective, which ones work and don't work. So the next 3 slides, I've divided the dietary supplements into 3 categories. So this first one are ones that have some evidence backing them up. Next one is going to be things that have no evidence backing them up. And the third are going to be things that are probably dangerous and that our patients should not take at all. So on the first slide, we see the 2 best studied dietary supplements are just simple over-the-counter agents. So the first is Valerian Root, which is used quite commonly, especially in Europe, maybe a little less so here. And there's certainly studies suggesting that it works for people. But the issue with Valerian Root is that the efficacy tends to be variable and unpredictable. And it also has some side effects like GI upset and headache. The first generation H1 blockers like diphenhydramine, that's obviously not a dietary supplement, but it's an over-the-counter agent. And it really does seem to work well in some populations. The problem with diphenhydramine is that it can also produce some side effects like daytime sedation, GI upset, headache. And there are long-term studies that have shown that in the elderly, it can contribute to cognitive issues and difficulty functioning during the day. And there are other studies that look at long-term treatment with anticholinergic agents and shows that they can produce changes in the central nervous system structure. And even though diphenhydramine is an antihistamine, it also has anticholinergic properties, and certainly that would be something you'd worry about with a patient who is chronically using diphenhydramine for sleep. The second group of agents are ones that have insufficient evidence for hypnotic efficacy. Certainly there's anecdotal reports of benefit, and a lot of our patients do find these helpful. There's just really no good clinical scientific evidence supporting that they consistently benefit sleep. But these are chamomile, lemon balm, St. John's wort, niacin, magnesium, B12, and again, many of our patients are already using these with varying degrees of effectiveness. This third category are the ones that really both have no evidence and are also potentially dangerous for our patients. So things like skullcap, wild lettuce, they can be hallucinogenic. Skullcap also is associated with seizures. 5-HTP at low doses is associated with GI side effects, but can actually be very dangerous, especially when patients unknowingly combine them with serotonergic agents or take doses that are too high and put themselves at risk for serotonin syndrome. Finally, kava has recently been taken off the shelves in many different countries, primarily because of the possibility of hepatic toxicity associated with kava. Finally, we're going to talk a little bit about melatonin. Melatonin's a neurohormone, and many of our patients use it. We often recommend it. There's a meta-analysis of 19 placebo-controlled studies of more than 1,600 participants, and it showed that it does have some possible effects which are quite modest, much more modest certainly than CBT, as you can see. So the reduction in sleep latency is about 7 minutes. Total sleep time was increased by about 8 minutes. And there is also a modest improvement in quality. So it can be somewhat useful. The problem is its effects are pretty unpredictable and oftentimes so modest that our patients simply don't retrieve the kind of predictable benefit that they're hoping for when we offer melatonin. So it's important if you're recommending melatonin to really set the patient's expectations. Another issue that's been raised with melatonin include those of possible negative effects. So this was a study, for example, that showed acute melatonin administration resulted in an increase in blood glucose levels in the morning. And also at that same time, there was no change in the insulin level. That is, insulin levels remained the same, but blood glucose levels increased in the morning. And then when they look back in the afternoon and the evening, that glucose level remained high, and the insulin levels were also high. So, what this tells us is that melatonin resulted in an increase in blood sugar levels, which insulin wasn't able to compensate for. So there was an insulin resistance that built up among these patients as the evening approached. And the thing to remember about melatonin is that many of our body organs have melatonin receptors. Melatonin's an important signaling system in animals that triggers our brain to kind of signal ourselves to rest, kind of reset the body and alert the body about possible changes in photoperiods, so changes in the length of day, changes in season, and gets our body's physiologies prepared in anticipation of oncoming seasons. So, that role of melatonin receptors and melatonin molecules is the reason why there's a ton of them throughout our body. And by ingesting melatonin, even though it may produce better sleep in some cases, you may also potentially cause activation of a large number of peripheral receptors across multiple organ systems, which can cause unwanted side effects like insulin resistance. Melatonin also can be a significant problem for oncology patients because it can decrease the sensitivity of certain receptors that chemotherapeutic agents bind to, making them less effective. There are also some studies that have shown among male rats diminished fertility rates after melatonin administration. So melatonin may work initially, but and it also may seem benign because our body produces it naturally, but chronic indiscriminate use is something you should be thoughtful and careful about. All right, getting on to the prescription agents for insomnia. How much time do we have left? Or do we stop at 10 of or on the hour? And we're going to try and power through. I think we have enough time if it's on the hour, but
we still do it.
Okay, great. So we're going to start talk about some of the FDA-approved sleep medications as well as some of the non-FDA sleep medications that we use. So let's first talk quickly about antipsychotics and anticonvulsants and antidepressants, which fall in the non-FDA approved sleep category. So I think sedating antidepressants are probably most commonly used agents like trazodone at low doses like 50 milligrams. We also might use mirtazapine, paroxetine, Doxypen. Doxypen actually is FDA approved for sleep. We'll talk about it in a minute. Certainly for patients who have a comorbid mood disorder, this is a good strategy. But if there is no comorbid mood disorder, treating chronically with these agents, you want to think about the risk-benefit of potential side effects, especially if you have other serotonergic agents on board or agents that induce the CYP metabolic syndrome and increase the serum concentration of these agents. In terms of safety, mirtazapine is the agent that probably has the fewest CYP interactions. It also is less commonly associated with hyponatremia than some of the other antidepressant agents. So if you're going to use one of these, like for maybe an elderly patient with lots of medical comorbidities who's on other medications, mirtazapine might be a good option. It also can help stimulate appetite. So if the person is malnourished and needs to consume more food, it can be helpful in that way. It's also less associated with hypotension and falls than, say, trazodone is. Antipsychotics, I think many people use Seroquel or Quetiapine as an augmentation strategy for patients with insomnia, or even as a single agent. I think to use something like Quetiapine, which has significant potential for side effects like orthostatic hypotension, metabolic burden, as well as other stuff, doesn't make a huge amount of sense. But if the person has a comorbid psychotic or mood disorder, I think starting Quetiapine as an adjunct to help address sleep is not a bad idea. Quetiapine doesn't have any superiority in terms of its sedating potential compared to other similar antipsychotics in its class. It's really used most commonly primarily because of its pharmacokinetics. It's just going to reach a T max and enter into the CNS a little bit more quickly than some of the other similar antipsychotic medications, which is why I think it tends to be so commonly used for sleep issues. But again, it is not FDA approved for insomnia. So this question is just to break things up a bit and start to think about some of the FDA approved agents. And I'm asking you guys to think about which neurotransmitters are involved in the generation of sleep: histamine, GABA, serotonin, norepinephrine, or epinephrine. I'm going to answer this for you guys in the support of the time. So the answer is GABA. So the first choice, histamine, it's actually antihistamine that promotes sleep. Serotonin is completely unhelpful for sleep, and in fact, it can cause restlessness and disrupt sleep architectures in some patients. That's why oftentimes in our clinics, patients who are just started on an antidepressant medication might feel a little bit of insomnia, and then norepinephrine and epinephrine do not generate sleep. So in order to understand the role of these neurotransmitters in sleep, and also to think about what hypnotic sleeping pills do, remember that, so we're going to talk a little bit about the arousal system. And hopefully all of you are using your arousal systems right now, I hope. But arousal involves the ascending neurons from the brainstem all the way up to the cortex. And the neurotransmitters we just mentioned in the last slide, norepinephrine, acetylcholine, dopamine, histamine, and serotonin, are all involved in this wakefulness system through these ascending neurons going up to the cortex. Another neurotransmitter, which many of you may not be as familiar with, but also is involved in arousal, is called the Hypocretin neurotransmitter system. It's also called the Erection System. Really, hypocretin and orexin are synonymous and interchangeable. They mean the same things. These cell bodies are located in the posterior lateral hypothalamus, which is also referred to as the perifornical region. And it's the Erection System that not only helps wakefulness, but also it impinges on all of those other neurotransmitters we just mentioned in the last slide, and controls the manner in which they promote wakefulness in a coordinated fashion. And so really it's the Erection System that is kind of the driver's seat of the wakefulness arousal system that helps to coordinate it in conjunction with our sleep system, which we're going to talk about in a second. So our orexin controls the neurotransmitters involved in wakefulness. So take-home point. So the sleep system involves kind of acts in equilibrium with the wakefulness system. The sleep system's mediated primarily by GABA. There's also another chemical called galanin, which is involved in sleep to some extent, but not as much as GABA. GABA is located in the ventrolateral preoptic nucleus, or at least that's where its cell bodies are located. And it's really the balance between these two systems, those ascending neurotransmitters mediated by orexin, as well as GABA, that helps your body to decide whether you're going to be awake or asleep. And then you have your circadian rhythm that feeds into this. Circadian rhythm is mediated by melatonin. So, you have this sleep-wake system with ascending neurotransmitters on one hand and sleep-promoting GABA system on the other that exists with one another to kind of create this normal sleep-wake pattern, also modified by our circadian rhythm. So going on to the orexin system for just a sec. So that this is a system of neurotransmitters. They're comprised of small peptides. They're in the dorsolateral hypothalamus, as I just mentioned. And some research has found that they're also involved in other areas really having nothing to do with arousal. Things like locomotion, metabolism, blood pressure. There's also some recent data that shows that orexin is involved in mood states and depression. So in the beginning of the talk, when I was asking about whether sleep can have an impact on some of its commonly comorbid medical issues, research into the orexin system might provide some clues that of how insomnia impacts our physiological health as well as our mental health. And there's going to be more research coming out on that. And in terms of design for new sleeping agents, agents kind of targeting the orexin system tend to be kind of the primary area of focus for pharmaceuticals. How are we doing on time? Do we have like 5 or 10 more minutes? Okay, I'm going to go until I'm told to stop talking. So benzodiazepines, they're from a sleep standpoint that they're really good at initiating sleep and promoting sleep, but they're not super well studied. So, benzodiazepines is an older class of medication. The ones listed on this slide, we don't tend to use as much. I think Klonopin and lorazepam are probably the two most frequently prescribed. The issue is most of the studies looking at benzodiazepines for sleep, or at least the ones that allow them to gain FDA approval, stopped after 30 days. And so for this reason, you really should not use benzodiazepine agonists for more than 30 days at a time, because the data just isn't there to evaluate whether when it's safe and whether it continues to be effective. And we know that people often build both a physiological and a psychological dependence on benzodiazepines. And certainly as people get over the age of 65 and have been on them for years and years, you want to try and get them off. And that's actually a place where CBT for insomnia can play a good role. So let's go on to the Z drugs. We're going to start with a question. You have a 6-year-old guy who's complaining of insomnia. He falls asleep rapidly after going to bed, but wakes up repeatedly through the night. He usually wakes at like 1 or 2 in the morning. After he's already fallen asleep, he feels tired the next day. So which of these is the least appropriate? Zolpidem, Ramelteon, Zopiclone, low-dose Doxypen, and Suvorexin. So the answer here is actually Ramelteon. And the reason for that is Ramelteon is useful for getting people to fall asleep, but not to stay asleep. And these other agents are much better at making sure a patient stays asleep. So here's some of the benzodiazepine receptor agonists. You have Zalpilon, which is Sonata, Zolpidem, which is Ambien, extended release Ambien, Ecopipam, which is Lunesta. All of these are great at getting you to fall asleep. So if a patient says, I just can't fall asleep, these are going to be effective in getting the person to fall asleep. But only extended release Ambien and Ecopipam, which is Lunesta, are going to be beneficial for people who tend to wake up after initially falling asleep. It's important to remember that all of these agents are Schedule 4 agents. They have a very high addiction potential. There's also metabolism differences between biological men and biological women. And so when treating people of different biology, you want to make sure that you start at different doses and titrate differently. And then for the non-benzodiazepine agents, Melatonin's a melatonin receptor agonist. It only does one thing, it puts you to sleep. So if you have someone who wakes up a lot after falling asleep, Melatonin's not the right agent for them. Doxypen is a older class of antidepressant, a tricyclic antidepressant. They're not used as frequently because they have a lot of anticholinergic and alpha adrenergic side effects and can be associated with cardiac toxicity. However, low dose Doxypen at 3 milligrams or 6 milligrams really has zero alpha adrenergic effects and zero anticholinergic effects. It really works primarily as a histamine at those doses. And it's not great for someone who can't fall asleep, but it is good for people who wake up after falling asleep just because its effects are a little bit slower to have onset and a little bit longer lasting. And then there's Suvorexin, which is actually targeted on the Erection System, that wakefulness system we talked about. And Suvorexin is good both for sleep maintenance and for initiating sleep. It is a Schedule 4 agent, so it certainly has very high addiction potential. Melatonin and Doxypen are non-scheduled. Those agents do not run a risk of misuse, so those are advantageous for patients who maybe do have a drug abuse history. And you want to avoid Suvorexin in patients with abuse histories. There's some variants. There's a sublingual and a spray form of Zolpidem. These are good for patients who don't like to take medication, but want some sort of rescue treatment if they wake up in the middle of the night. So most people who wake up in the middle of the night and can't fall back asleep, unfortunately, by the time they're waking up, it's too late for them to take another agent to fall asleep. So these medications bypass first pass metabolism and have very rapid onset and offset, and they can be useful for people who really don't want to take a sleeping pill unless they absolutely have to. And who unfortunately, by the time they realize they have to, it's too late for them. You have to have at least 4 hours left to sleep in order to take them. But so if you wake up at 3 in the morning and you don't have to wake up till 7 or 7:30, this could be a useful agent to fall back asleep with. Here's some of the adverse effects of the hypnotics. I'll let you guys read those on your own. And then when thinking about what to choose, first get an idea of what the person needs. Initiation or maintenance, do they need to fall asleep or do they need to stay asleep? That might affect your choice, or the patient might need to both have help initiating sleep and maintaining sleep. And there are certainly agents that are effective at doing both of those things. I didn't talk about this much, but Melatonin and Suvorexin are a little bit safer for patients who have sleep apnea. So the non-selective benzodiazepine agonists also end up causing smooth muscle relaxation, which means patient's airway can collapse on itself, and that would worsen symptoms of sleep apnea. So, and if that person's, they're on BiPAP already, but their BiPAP gets knocked off in the middle of the night, and they've taken, Klonopin, a benzodiazepine, they're going to get into trouble. So Melatonin and Suvorexin are not associated with that smooth muscle relaxation, and they're probably safer agents to use. The selective benzodiazepine agonists like Ambien are a little bit safer than the non-selective agents like Klonopin for people who have sleep apnea, just because they're more focused on the benzodiazepine 1 receptor and are not as associated with that smooth muscle relaxation. Romeltian and Doxypen have the lowest abuse potential. So if substance abuse is something that you're thinking about with your patient, those might be good agents to start with. You also, you want to consider what the patient wants, what has worked for them in the past, what hasn't worked for them in the past, and also what they feel like might be the best medication for them based on the informed consent and conversation that you've had with them about different agents. And that is it. It's 3 o'clock. So thank you guys so much. Hopefully I did not put any of you to sleep. And I will see you guys on the floors.
Thank you so much, Dr. Kopple Perry. Guys, do you have any question? I can allow one question if you have anything. Otherwise, you can also email Dr. Kopple Perry if you have more questions.